Puberty Disorders Dr. Sarah Mohammed. MBBS, FRCPCH UK, MRCP, UK, MRCPCH UK, DCHIA, CCSTIA, CPTIA, MD. Consultant Pediatric Endocrinologist and Metabolic Physician. Assistant Professor of Pediatrics. King Saud University. Definition of puberty. What is puberty? It is the transitional period of development during which an individual matures from childhood to physical, psychosocial, sexual and reproductive maturity. Puberty. Gonadal maturation with acquisition of secondary sexual characteristics and associated growth spurt, fertility and final height. Endocrine regulation. Negative feedback, female, insert figure 20.9 male. Inhibits GnRH from hypothalamus. Inhibits anterior pituitary response to GnRH. Inhibin secretion. Inhibits anterior pituitary release of FSH. Female. Estrogen and progesterone. Male. Testosterone. Insert figure 20.9. Onset of puberty. The age of onset of puberty. Average age of onset. Females 8 to 13. Males 9 to 14. Average age of onset. Girls 10 to 11 years, range 8 to 13 years. Boys 11 to 12 years, range 9 to 14 years. First sign of puberty in females is breast development, and testicular enlargement in males. Axillary and pubic hair follows along with other tundry sexual characteristics. The maximum growth velocity occurs at 12 years. The age of menarche has decreased over the last 3 to 4 decades due to improved nutrition, general health and lifestyle. Menarche marks the attainment of reproductive maturity. F2 pubic hair is the first visible physical sign of puberty. T3 the maximum growth velocity occurs at 12 years. T4 the age of menarche has decreased over the last 3 to 4 decades due to improved nutrition, general health and lifestyle. F5 menarche marks the attainment of reproductive maturity. Duration of puberty. The time from onset to completion of puberty. Average 4.2 years. Range 1.5 to 6 years. Factors that affect puberty. Genetics. Race/ethnicity, blacks before white. Previous nutrition, malnourished they go to puberty later. Subcutaneous fat, overweight reach puberty faster. Obesity. Increased leptin and estrogen production. Insulin stimulation of ovaries and uterus. Birth weight, initial signs of puberty. Girls, breast development. Boys, testicular enlargement. Volume greater than 3.0 cubic centimeters. Length greater than 2.5 centimeters. Growth in puberty. Female enter growth spurt before males because females, around 10 years, enter puberty before males, around 12 years. Insert figure 20.10. Evaluation of disorder of puberty. Clinical assessment. History. Behavioral changes. Pubertal staging. Skin examination. Height measurement, growth velocity. Bone age assessment. Hormone study if needed. Assessment of puberty history. Parents. Onset of puberty. Menarche. Male age of first shaving regularly. Parental heights, mid-parental height. Prenatal and perinatal, exposure to exogenous sex steroids in intrauterine period, birth weight, perinatal asphyxia. Concomitant illnesses, postnatal exposure to sex steroids. Time of first sign of puberty. Thelarche, galactorrhea, development of breast, testicles. Adrenarche/pubarche, body odor, axillary and pubic hair, acne, development of pubic and axillary hair. Menarche menstruation. Gonadarche. Premature thelarche is different. The precocious puberty. Premature thelarchy is different than precocious puberty. Premature thelarchy is when there is breast or testicular enlargement before the age of 8 or 9 years in females and males respectively. In premature thelarchy, the X-ray images and hormonal levels are normal with no other signs of puberty. History important to include: past medical history, history of brain tumor, radiation, chemotherapy, known genetic disorder, chronic disease affecting growth, eating habits, any evidence of disordered eating, activity level. Is exercise excessive, or is this an athlete with a high level of training? Growth history. Previous growth chart can be extremely helpful. History review of systems. SNES, visual changes/visual field abnormalities, headaches, anosmia. Cardiac, congenital anomaly. Respiratory, asthma. Renal. GI, diarrhea, blood in stools. Physical examination of growth. Height. Weight. Pubertal assessment, Tanner staging. Axillary hair. Pubic hair and staging. Breast development and staging. Genital development and staging. Skin, hair, thyroid. Neurological assessment, growth charts. Staging of pubertal development in girls, Tanner. B1 to 5, PU 1 to 5, A1 to 5, B2, first sign of female puberty. Staging of pubertal development in BS, Tanner. G1 5, PU 1 to 5, A1 to 5, testicular volume greater than 4 milliliters, first sign of male puberty. It's used to measure the testicular size and development. Prada orchidometer along with Tanner staging is used to assess puberty in males. Diagnostic evaluation. Laboratory. Gonadotropins, FSH, LH, basal and peak after LHRH stimulation, prepubertal LH/FSH less than 1. Estradiol. Testosterone, basal value and value after LH stimulation. Adrenal androgens, 17-OHP, ADL, and ACTH. Bone age by hand X-ray. Pelvic US, ovarian and uterine size. CT or MRI of adrenals, brain to exclude tumors. Vaginoscopy. Genetic, karyotype, DNA analysis. Bone age. 2 years 6 meters. 10 years. 12 years. Summary variants of puberty. Premature thelarchy. Only premature breast development, with normal hormones. Exclude the start of precocious puberty. Premature adrenarche. Only premature axillary and pubic hair, with normal hormones. Exclude simple viralizing form of CAR. Premature menarche. Exclude vaginal bleeding due to trauma of vagina or ovarian cyst. Bone age is not accelerated. FSH and LH levels after LHRH are normal. Gonadal and adrenal steroid levels are normal. Pelvic and adrenal ultrasonography is normal. Reassurance and FU. Precocious puberty. Landmark case of precocious puberty. 5-year-old Lena Medina of Peru. Menses onset age 8 months. Breast development age 4. Advanced bone maturation age 5. Was evaluated for abdominal tumor due to increasing abdominal size at age 5. On the 14th of May 1939 gave birth to a 2.9 kilograms baby boy. Definition of precocious puberty. Onset of puberty before. Females 8 years. Males 9 years. Lawson-Wilkins Pediatric Endocrine Society recommended 7 for white girls/6 for black. Prevalence is estimated to be between 1 in 5,000 to 10,000 children annually in the United States. They can conceive Classification central, true, gonadotropic dependent. Early stimulation of hypothalamic pituitary gonadal axis. Idiopathic. Peripheral resistance, GnRH independent, precocious pseudopuberty. The source of sex steroid may be endogenous or exogenous, gonadal or extragonadal, independent of gonadotropin stimulation. Look for ovarian tumor. True precocious puberty, central, GnRH dependent. Idiopathic, constitutional sporadic or familial, common. SNES abnormalities. Congenital, hydrocephalus, arachnoid cysts. Acquired pathology, post-traumatic, infections, radiation. Tumors, LH-secreting pituitary microadenoma, glioma, may be associated with neurofibromatosis, hamartoma. Reversible forms, space-occupying or pressure-associated lesion, abscess, hydrocephalus. Adopted children or children emigrating from developing countries. Improved nutrition, environmental stability and psychosocial support. True precocious puberty, central, gonadotropin dependent. Bone age is accelerated. FSH and LH elevation after LHRH is diagnostic test. LH/FSH greater than 2. LH/FSH ratio less than 1 prepubertal. LH/FSH ratio greater than 1 pubertal. MRI of SNES is necessary to exclude the neoplasia. Treatment of true precocious puberty. Purpose of treatment: to prevent psychosocial distress, to improve final height outcome because growth will stop at that age, resulting in short stature. Treat the underlying cause. GnRH analog. Lupron-depoped, liprolide acetate. Desensitizes the pituitary. Blocks LH and FSH secretion. Prevents continued sexual development for the duration of the treatment. Growth may almost stop while on therapy. Plus-minus addition of growth hormone remains controversy. Precocious pseudopuberty in girls, gonadotropin independent. McCune-Albright syndrome. Ovarian cysts. Isolated follicular cysts with E2 production. Self-limiting with spontaneous regression. Ovarian tumors. Acceleration of bone age. FSH and LH are low after LHRH stimulation. Estrogens are elevated. Precocious pseudopuberty in boys, gonadotropin independent. Congenital adrenal hyperplasia, CAH. Undiagnosed or inadequately treated simple viralizing form of CAH caused by 21-hydroxylase deficiency. Neonatal screening. Testotoxicosis. Activating mutation of LH receptor. Adenheredited. Tumors. Gonadal, testosterone-secreting Leydig cell tumor. Adrenal, adenoma, carcinoma. Exogenous androgens, anabolic steroids, iatrogene, doping. McCune-Albright syndrome. Acceleration of bone age. FSH and LH are low after LHRH stimulation. Testicular or adrenal steroids are elevated. Precocious puberty treatment. Gonadotropin-dependent PP. Idiopathic. GnRH, LHRH, analog to block LHRH receptor of pituitary gland. Organic, tumoral cysts. Surgery. Gonadotropin-independent, pseudopuberty. Treat underlying cause. Testicular, ovarian or adrenal tumors surgery. CAH, substitution of corticosteroids. Delayed puberty. Delayed puberty, definition. Initial physical changes of puberty are not present by age 13 years in girls, or primary amenorrhea at 15.5 to 16 years. By age 14 years in boys, types of delayed puberty. Gonadotropin dependent. Hypogonadotropic hypogonadism. low LH/FSH. Central, chronic disease. Gonadotropin independent. Hypergonadotropic hypogonadism. High LH/FSH. Peripheral cause, gonads, GnRH or gonadotropin dependent. Idiopathic. Sporadic or familial, associated with constitutional growth delay. Chronic diseases with bone age delay and growth retardation due to different pathophysical mechanisms, malnutrition, anemia, acidosis, hypoxia, anorexia nervosa, cystic fibrosis, chronic renal insufficiency. Psychosocial deprivation. GnRH or gonadotropin dependent. Hypogonadotropic hypogonadism. Gonadotropin deficiency. LH only, fertile eunuch syndrome. FSH and LH. Congenital, genetic, syndromes, Kallmann syndrome, mutation of KAL gene, mutation of DAX1 gene, Prader-Willi syndrome. Acquired, cranial irradiation, hemosiderosis, granulomatous disease. Associated with others pituitary hormones deficiencies. Congenital, empty cellar syndrome, genetic transcription factors, disruption of pituitary stalk, breech delivery. Acquired, tumors, inflammation, irradiation, trauma. Kallmann syndrome, a syndrome of isolated gonadotropin deficiency. 1/10,000th males, 1/50,000 females. KAL1 gene. Present with anosmia or hyposmia. Can also be associated with hair lip, cleft palate, and congenital deafness. Syndromes associated with pubertal delay. Prader-Willi syndrome. Lawrence-Moon syndrome. Septo-optic dysplasia. Bardet-Biedl syndrome, gonadotropin independent, hypergonadotrophic. Boys. Congenital. Anorexia. Chromosomal abnormalities, Klinefelter syndrome, Noonan syndrome. Disorders in androgen synthesis or action. Acquired. Autoimmune inflammation, APS. Radio or chemotherapy. Traumatic. Surgery, Klinefelter syndrome. 45XC most common, 2/3. Tall in childhood, with eukaryoid body habitus. More female type fat distribution. Puberty is delayed. Small testicles and gynecomastia. 90 to 100% are infertile. Klinefelter syndrome. A 19-year-old phenotypic male with chromatin-positive seminiferous tubule dysgenesis, Klinefelter syndrome. The karyotype was 47, XXY, gonadotropin levels were elevated, and testosterone levels were low. Normal. Note normal viralization with long legs and gynecomastia, B, C. The testes were small and firm and measured 1.8 times 0.9 centimeters. Testicular biopsy revealed a severe degree of hyalinization of the seminiferous tubules and clumping of Leydig cells. D. A 48-year-old male with 47, XXY Klinefelter syndrome with severe leg varicosities. Williams Textbook of Endocrinology, 10th ed., 2003, previous photos. A 19-year-old phenotypic male with chromatin-positive seminiferous tubule dysgenesis, Klinefelter syndrome. The karyotype was 47, XXY, gonadotropin levels were elevated, and testosterone levels were low. Normal. Note normal viralization with long legs and gynecomastia, B, C. The testes were small and firm and measured 1.8 times 0.9 centimeters. Testicular biopsy revealed a severe degree of hyalinization of the seminiferous tubules and clumping of Leydig cells. D. A 48-year-old male with 47, XXY Klinefelter syndrome with severe leg varicosities. Gonadotropin independent, hypergonadotrophic hypogonadism. Girls. Congenital. Bilateral ovarian torsion. Chromosomal abnormalities, Turner syndrome, pure gonadal dysgenesis, Noonan syndrome. Acquired. Autoimmune inflammation, APS. Radio or chemotherapy. Traumatic. Surgery. Turner syndrome. Karyotype 45, X, 60%, 45, X/46, 20, structural abnormalities of X chromosome. Incidence 1/2000. Short stature, final height 142 to 147 centimeters. Web neck. Gonadal dysgenesis, streak gonad. Autoimmune, Hashimoto's thyroiditis, Addison's. Mild insulin resistance. Essential hypertension. Hearing loss/no mental defect. Impairment of cognitive function, mathematical ability. Visual motor coordination, spatial temporal processing. Y chromosome predisposed to gonadoblastoma. H. Turner, 1938. Investigation of delayed puberty. Investigations depend on clinical presentation, but may include bone age, hormone levels, IGF-1, FSH, LH, estradiol, testosterone, YAS, prolactin, TSH. Karyotype. Hormone stimulation tests. RH stimulation test. GH stimulation test. Imaging. MRI brain if gonadotropins low and no obvious cause of hypogonadotropic hypogonadism. US or MRI pelvis.